So from the insertional tendinopathy, we move on to the non-insertional tendinopathy. We know there is a watershed area in the tendocalcaneus, which is just 2 to 6 centimeter above. So non-insertional Achilles tendinopathy is basically an overuse condition. This is commonly seen in athletes, both professionals and the ones who indulge in recreational activity. So there is micro ruptures and there is attempt at repair. This is most common in middle and long distance runners, and the pain is the most common presenting symptom. This pain occurs generally about after a period of rest or when they wake up after a sleep. And there's also a swelling. Swelling would be over the posteromedial side of the tendon, and there would be nodular swellings there. So what happens? Because there are attempts at repair, but these attempts rather fail. So this condition is because of both inflammation and degeneration, and because of this, there's loss of normal architecture, and there would be hypercellularity and new vascularization. This new vascularization causes also formation of new nerve endings, which are generally cause of the pain. Apart from these things, there are certain intrinsic factors. There are certain patients which are more predisposed. We know in these patients, there could be low limb malalignment, there could be limb length discrepancy. Some patient might have limited ankle dorsiflexion. Certain extrinsic factors also aid to the development of this pathological condition. Those are like errors in the methods of their training. Certain drugs like steroids and fluoroquinolones, they also cause a gradual degeneration at the area of the watershed and causing this problem. There's also been seen a strong association with conditions like diabetes, like obesity, like hypertension. It is worthwhile here to note that the non-insertional Achilles tendinopathy can be a gamut of 3 conditions. It could be a purely paratendinitis, where only the paratenon is affected, like the picture on the left, where just the tendon is affected, just the paratenon is affected, or it could be pure tendinopathy, where the paratenon is fine, but inside the tendon, in the substance of tendon, there is pathology, or it could be a combination of both. There are certain clinical tests. There would be thickening of tendon on palpation. There would be pain on palpation. There could be crepitus. There are certain tests like Royal London Hospital test and painful arc syndrome. I'll be talking about them in the next slide. And there could be also, when we do tests like tendon loading test, there will be pain on passive dorsiflexion and pain on a single heel raise and pain on hopping as well. So what is this Royal London Hospital test? The patient is laid prone on the examination table with the leg and the foot hanging outside with a little plantar flexion. We could locate the site of pain, and when the patient is asked to dorsiflex, the pain will move. This movement is also because of the tendon which is moving, which is getting stretched. This is also known as the painful arc syndrome. So investigations, we can have routine investigation, but ultrasound and MRI are most conclusive test. X-ray are rather not helpful because there will be no changes until there is calcification. So what do you get? Ultrasound, especially in Doppler ultrasonography, there would be area of neovascularization. This neovascularization can be seen in this kind of ultrasonography, and we would understand that along with neovascularization, there's formation of new nerves as well. New nerves, what we call new nerves. So these new nerves, generally they cause pain. So if we can see neovascularization in ultrasonography, we could say that this is, yes, the disease is there. An MRI, this is considered better in characterizing a degeneration of tendon, like we can see in the picture on the right side. However, ultrasound is more cost effective. They are less costly and they are generally easily available also. As far as treatment is concerned, it is mainly conservative. because about two-thirds of the patient will benefit from the conservative treatment itself. The usual NSAIDs are there. Then we have, of course, to remove the precipitating factor and eccentric exercises. Those eccentric exercises are most useful in which a contracted gastrosoleus is stressed. So that's why this is called eccentric exercise. There, sometimes we can also have eccentric concentric exercises going on to eccentric exercises. Then there is something called as low energy shock wave therapy. So let's talk of first the eccentric stretching exercises. Something called Alfredson protocol is there, in which the patient is asked to perform exercises as shown in the figure, and 3 sets of 15 repetition twice a day for 12 weeks is done. It is found to be very useful. And as far as the low energy shock wave therapy is concerned, this is supposed to be acting on 2 planes. They not only help in healing of the wound, they also block the pain pathway. They somehow block the transmission of the pain, and thereby they provide relief from the pain. Role of PRP, not very conclusive. There are conflicting reports in the literature. My friend Chua just told that in certain cases of insertional, where there is no calcification, he has found this PRP to be useful, but yes, the juries are still out as far as the use of PRP is concerned in non-insertional tendinopathy. Surgery, yes, only about 1/3 of the patient in which the conservative treatment is failing, doesn't help. In those patients only open surgery is required, which could be open surgery, could be minimal invasive modern methods. In open surgery, what we do, we provide a long longitudinal incision. The incision is given in such a way that paratenon is incised along with the skin. There is no dissection in between, just to preserve the blood supply of the paratenon. And then the tendon is incised longitudinally. All the pathological tissues, they are divided out, and there is then side-to-side repair of the tendon. Many times, even this much is sufficient, but if this excision of the pathological part of the tendon is more than 50%, we may require to augment our repair with FHL transfer. How FHL transfer is done, it has already been explained by the previous speaker, so I will not go into detail, but we have to keep in mind that if we are removing more than 50% of tendon, we have to do some augmentation. Minimal invasive methods, we could do something like endoscopic way, and sometimes there are multiple longitudinal incisions are given percutaneously, and tenotomy is done. And sometimes there is a resection of plantaris because it is seen that the pain is more on the medial side, and somehow the removal and the resection of plantaris help in alleviating the symptoms. Complications of the surgery, we all know, especially when treatment is by open surgery, there could be wound edge necrosis, wound infection, ceratoma, hematoma formation. There could be fibrotic reactions, and therefore there could be long scar over there. If you don't take care, sometimes even by the minimum invasive method, there could be sural nerve irritation and damage to the nerve. Tendon rupture could be there. The other complication, of course, could be thromboembolic disease and excessive scar formation. So this is what I can tell in this 10 minutes. Thank you so much, sir. Thank you.